Καλησπέρα σε όλους. Έχουμε μαζί μας σήμερα τον καθηγητή κύριο Thorsten Kühn από τη Γερμανία, ο οποίος είναι ο άνθρωπος που έχει ξεκινήσει τη μελέτη AXSANA και στην οποία συμμετέχει και η δική μας κλινική και θα μας μιλήσει για τους σκοπούς αυτής της μελέτης. Dear Professor Thorsten Kühn, it is a great honor to have you with us today. We look forward to your speech and we appreciate your coming all the way from Germany to share your knowledge about the AXSANA study. You may now proceed with the rest of the presentation. Thank you very much.
Okay, ladies and gentlemen, dear Professor Ξεπαπαδάκης, no.
Yes.
I try my best. Yeah. Dear Lázaro, thank you very much for the kind invitation.
It's a good effort anyway.
So first of all, thank you so much for the kind invitation. It was a great pleasure to come here for several reasons. And when I received the invitation from Lázaro, I was very happy because there are two main reasons. First of all, we founded an organization in 2018 called EUBREAST, the European Association of Surgical Trialists, and the intention was to bring surgeons from all over Europe together and improve collaboration and improve research on surgical issues. And the Greg team was very strong. One of our first studies that we implemented was the AXSANA study that we will discuss today. And we are a very strong team here in Greece. And so I think this represents the idea that we had in 2018 to come together as surgeons, do joint trials, and learn from each other. So thank you again for this invitation. So today we want to discuss the AXSANA study, which in fact is the first major trial of the EUBREAST study group. These are my disclosures. And let me start with some basic statements. So you all know that neoadjuvant treatment of breast cancer becomes increasingly important. We all know this. We can de-escalate surgery to the breast, and we will not discuss the breast today. We will mainly talk about the axilla and the lymph nodes, and we will discuss how we can reduce the extent of surgery to the lymph nodes. We have, and this is the main reason why the neoadjuvant approach has become a standard in many breast cancer patients. We have the option to tailor treatment according to response to chemotherapy and improve event-free survival, even overall survival. So this has changed. We can influence the outcome of patients, of many patients, with a neoadjuvant approach. And in addition to that, there are some agents that only are effective given preoperatively, and this is the Keynote 522 study that you probably know with the use of pembrolizumab using in the neoadjuvant setting. Pembrolizumab, in addition to taxane-based chemotherapy, can improve event-free survival when given preoperatively. And interestingly, it has no effect when given in the adjuvant setting. There have been some studies. So there are some drugs that only work in the neoadjuvant approach, and this is one of the reasons why this approach is becoming increasingly important. The other one is the option to have a post-neoadjuvant treatment and improve outcome by giving specific drugs after neoadjuvant chemotherapy and surgery, and the main study is the Catherine studies. You all know the Catherine studies, patients with HER2-positive disease treated with neoadjuvant chemotherapy and antibody. Those patients who do not achieve a complete response undergo additional treatment with in ADC, with TDM1, and it has been shown way back in 2018 that event-free survival could be improved by almost 50%, and at the San Antonio meeting last year, the overall survival data were presenting, showing that overall survival with the neoadjuvant approach and the post-neoadjuvant treatment with TDM1 improves overall survival by 4.7% in 7 years. So this is the rationale why in triple negatives and HER2 positive patients today, neoadjuvant treatment is a gold standard. And now we come to the surgical treatment of the lymph nodes. And as we have seen, that the PCR is an important factor to tailor further treatment. And how is the PCR defined? It's the pathologic complete response is defined as the absence of any residual invasive cancer on evaluation of the resected breast specimen and all sampled ipsilateral lymph nodes following completion of neoadjuvant chemotherapy. So we need assessment of the lymph node status to define PCR. And 10 years ago, we discussed doing X-ray staging before chemotherapy. We will discuss this shortly. By doing so, we could not define PCR because we need to know the lymph node status after chemotherapy. And therefore, we try everything to stage the axilla after chemotherapy in order to assess the YPA status. So what is the objective of X-ray surgery after neoadjuvant chemotherapy? First of all, I think this is important that X-ray surgery, lymph node surgery, becomes more and more diagnostic rather than therapeutic. So it provides diagnostic information to determine the YPA status and assess PCR and decide whether or not we need post-neoadjuvant treatment. Certainly, we perform X-ray surgery also in order to achieve region control, but we learn more and more that the surgical approach provides little benefit for local region control. It's rather a diagnostic procedure. The standard for X-ray surgery after neoadjuvant treatment was for decades full X-ray lymph node dissection. And here we can see the results of the Keynote 522, and we see the rate of patients that convert from node positivity to node negativity, and patients even who present initially with a CN1, 2, or 3 status convert with a rate of up more than 70% under here in this study under treatment with pembrolizumab from clinically node positivity to histologically node negativity. So we would overtreat more than 70% of the patients if we performed full axial lymph node dissection in these patients. Now, how do we perform X-ray staging after neoadjuvant chemotherapy? There were a lot of studies going on in recent years, and what has been shown was that for patients who present initially with a negative lymph node status, the false negative rate of central lymph node biopsy was 3.2%, which is okay. However, patients who presented initially with positive lymph nodes, it was shown, and we will see the studies in a moment, the false negative rate was much higher. It was 14.8%. And most surgeons felt that this was too high because we always accepted a false negative rate of 10%, but not higher. We said, okay, we don't know exactly what happens, but 14% is too high. Now let's go back to patients who present initially with negative lymph nodes, and it has been shown here in the Ghanea 2 study presented by Jean-Marc Claes, very nice study, showing that first of all, the detection rate represents the feasibility of the technique. Do I detect the sentinel lymph node? Is the technique feasible? And the detection rate was as high as 97%, so it works nicely. The recurrence rate, there was only 1 recurrence out of 419 patients within 36 months. So this technique for CN0 patients works perfectly and is safe. Therefore, patients with a CN0 status, central lymph node biopsy is perfectly feasible and reproducible. There's a high accuracy. So we have a reliable assessment of the YPN status. It is safe. We have little recurrences. And PCR can, and again, PCR can only be determined if we do it post-neoadjuvant. So it's clinically useful. And therefore, for this cohort, it's a gold standard. For 5 or 6 years, for CN0, we do the central lymph node biopsy procedure after chemotherapy. Now, these are data from the Sentinel study that we published in 2013. And in this study, we showed, first of all, what did we do in the study? So at that time, and we recruited patients between 2009 and 2012. And that time, we were not sure whether we should perform the central lymph node before or after chemotherapy. So we had one arm where we did central lymph node biopsy before chemotherapy. And then we had another arm, it's this one on the right side, where patients were node positive. They converted, and we did a central lymph node biopsy with a backup axial lymph node dissection to determine the false negative rate. And at that time, just to make you understand the history that we've been working on, at that time we discussed whether a second sentinel lymph node biopsy after a sentinel lymph node biopsy performed before chemotherapy might be a good thing to do. So what did we find? We saw that patients with upfront central lymph node biopsy in a multicentric setting of more than 100 institutions, the detection rate was 99.1%. So this works perfectly everywhere. It's highly reproducible. So in the untreated axilla, central lymph node biopsy works perfectly. We then saw for patients who had a central lymph node biopsy, which was then positive, and then should we go for a second central lymph node biopsy? And we saw the detection was only 60%. So it simply does not work, and so this procedure was abandoned completely. But patients who presented initially with a clinically positive lymph node and converted to node negative, the detection rate, and it's very important also to talk about detection as feasibility, was only 80%. So in 20% of the patients, the sentinel node biopsy did not work. We didn't find a sentinel node, and we had to move on to full axillary lymph node dissection. So these are the two studies, the Sentinel and the AXSANA study, and when we compare the false negative rates of these converters, we have false negative rate of 14%, and the NSABP B32 was the study that compared central lymph node biopsy with axillary resection in primary surgery. And this is the study that led to the acceptance of central lymph node biopsy in primary surgery. But one thing is interesting to know. So here we have, here, the false negative rate in this study was 9.8%. So it was not nothing. It was just below the 10% that we accept. Whereas for patients after neoadjuvant, it's 14%. We said, no, we don't accept 14%. But look at this. Even patients who have one central lymph node removed in upfront surgery, it was as high as 17%. Just keep this in mind. Why do I say this? You all know that we had a randomized trials very recently that compared sentinel node biopsy to nothing, the SOUND trial. And we found there was no difference in regional recurrences between the two groups. And now we have a discussion with many radiation oncologists saying, oh, you don't know the lymph node status, then we have to irradiate the axilla. This is a discussion many surgeons have. But then my proposal is just remember the NSABP 32 for the normal central lymph node biopsy. We also overlook positive lymph nodes, and we don't treat them. We just do our normal tangential field irradiation. So for these patients who convert, the false negative rate for one central lymph node was 24% in the Sentinel and 31% in the AXSANA trial, and certainly this is not acceptable. But does this have an impact on regional recurrence? We don't know. We just have an arbitrary cutoff of 10%, but we do not know what this clinically means. Nobody knows that. Why do we have this worse detection rate and the false negative? What is the reason for it? And this is a very old picture I've taken in the early days of central lymph node biopsy 20 years ago, where we were working with a blue dye alone. What you can see here, this is a positive lymph node at ultrasound, and here you can see the blue stained vessel, and here's the lymph node. And what you can see is that that a lymph node that is completely invaded by tumor cannot take up any tracer, blue dye or technetium, whatever. It's simply blocked. And here you have the lymph node completely invaded by cancer. So this lymph node is not able to take up the tracer and therefore cannot be identified as a central lymph node. And the consequence is that either you have a detection failure because you don't find the central lymph node, or you have a bypass and you have increased false negative rates. So this is a very simple explanation why the feasibility and detection does not work as well as it does in primary surgery. Now, knowing that the false negative rate was high and the detection was not good enough, there were several options analyzed to improve the false negative rate after chemotherapy. One was described in the Canadian FNAC trial to systematically use immunohistochemistry. And if you count patients with isolated tumor cells in lymph node or micrometastasis as node positive, then you can calculate a false negative rate of 8.4%. Or if you do a dual tracer. But all of these analyses were retrospective. And you can see here, so for the dual tracer, it was calculated. People often refer to the Sentinel trial. Yes, it was less than 8%, less than 10% with 8.6. But if you read the paper accurately, you will see that this was an unplanned retrospective study, and this is the result from the univariate analysis. If you look at the multivariate analysis, there was no difference between single tracer and dual tracer. Yeah? This is often overlooked. Another option was to remove more than 3 central lymph nodes. But how often do you find 3 lymph nodes? In Sentinel, we had 60% 2 lymph nodes. So all of these proposals were derived from retrospective analysis and were not really verified and doubtful. How can we improve the technique to improve the false negative rate, improve accuracy? And the first paper that was published here from Mila Donker in 2015, here a biopsy-proven lymph node was marked here with a iodine seed. And then this lymph node was removed. It was called the Mari lymph node, and X-ray resection was performed. And this lymph node was identified in 97% of the cases, and the false negative rate without a central lymph node biopsy, just removing the marked lymph node, was 7%. So quite impressive results. And this technique was then modified by a very well-known paper from Abigail Cordell, published in 2016. And here the Mari procedure, which was then called target lymph node resection, was combined with a central lymph node biopsy. And if you combine both procedures, you mark the biopsy-proven lymph node, you do a central lymph node biopsy, you remove both of these nodes, you come to a false negative rate of only 1.4%. This, however, was still retrospective. It was retrospective analysis from a prospectively database, so it's still hypothesis generating. But the next step was this paper from the Netherlands. Here the targeted X-ray resection, the removal of a marked lymph node, here with a iodine seed, combined with central lymph node biopsy in a prospective multi-center setting, the RESA study, published in JAMA 2022. This was the first really prospective and multicentric study. And here it was confirmed that the false negative rate was only 3.47%. So the combination of the central lymph node biopsy and the removal of a target lymph node revealed a false negative rate that was reliably between 10%. You see the confidence interval was between 1.3 and 7%. So this is appears a reliable procedure. And the detection rate for this target lymph node was more than 90%. Now, what are the techniques currently used in Europe? And this is a questionnaire that we distributed in 2022 from the EUBREAST study group. And here we can see what surgeons do throughout Europe. And what you can see that in 2022, the targeted X-ray section for patients with 1 to 3 positive lymph nodes was accepted by around 50% of the surgeons, while 25% still perform X-ray resection, and 25% still perform central lymph node biopsy, which is accepted in some countries. Italy, for example, Turkey, for example. They do central lymph node biopsy alone. They say, we don't care for the increased false negative rate. So there is a lot of discussion, and it is simply not clear. For patients who have more than three positive lymph nodes before surgery, still axial lymph node biopsy is the standard of care, but there are some surgeons who already perform target X-ray resection and less invasive surgery. So regarding the approach for patients who present initially with positive lymph nodes, there are still some uncertainties. So still we have insufficient outcome data on the oncologic endpoint. We know about false negatives rate, but we do not have many informations on the outcome. What is the best staging procedure? Target X-ray resection, target lymph node biopsy alone, or central lymph node biopsy alone? And how do false negative rates, and do they ever translate into higher recurrence rates? What is the effect on outcome, accuracy, life quality, health economics? What's the best localization technique for the target lymph node? Should we do a clip? Should we do a seed? Whatever. Is minimal invasive staging feasible and safe in patients with high tumor burden? N2. We don't know that. And what is the best treatment for patients who have a clinically negative but histologically positive lymph node after surgery? Can we go for radiotherapy, or do we have to go for axial lymph node resection? We do not know that. So there are many open issues that have to be resolved. What about outcome? Now the first data appear now on outcome after minimal invasive staging of the axilla, and these are the available data. This is a very interesting paper from Italy, from Viviana Galimberti, and what they did was, it is retrospective analysis, but 10-year follow-up. They do a very simple central lymph node biopsy. They remove one lymph node only with technetium, and they observed an X-ray recurrence rate of 1.8%. They did not remove 2 or 3 lymph nodes. They did not use dual tracer. Simple lymph node biopsy with an X-ray recurrence rate of 1.8%. So the CENTAR trial was a smaller German one, retrospective multi-centering, also 1.8%. They performed a target X-ray resection. The OMA trial that was presented in 2022 at the San Antonio meeting, they compared central lymph node biopsy and target lymph node biopsy with X-ray resection. Again, very low X-ray recurrence rate. And the last one presented in San Antonio last year was the Neo-Centi-Turk study presented by Neslihan Kayoglu. And they also, this was prospective multicentering, so it was the best data that we have, but it's not published as a paper yet. Again, very low X-ray recurrence rate. So whatever we do, the X-ray recurrence rate appear low, but still we do not know what's the best technique with less mobility. So these are German guidelines, and interestingly, the guideline committee still feels that data are not adequate to suggest target axial resection or less invasive surgery over axial lymph node dissection. I don't know what your recommendations are. So we still rate axial lymph node dissection equal as target lymph node biopsy as less invasive surgery, because the German guideline committee says, and it is very similar to the NCCN guidelines, we say we do not have sufficient outcome data to recommend less invasive surgery like target axial resection or central lymph node biopsy over axial resection. You see there's a plus and a plus, so there's equally rated. So there are still open issues. Can we really safely reduce the extent of surgery? There are still limitations. This is the reason why now we come to AXSANA. That's why we introduced the AXSANA study in 2020. And this is a simple registry. And you can include patients with a clinical node positive status. Then you can do what you want. You can do central lymph node biopsy alone. You can do target axial resection. You can go for axial resection. And we document everything. And we have now included 5,300 patients from 26 countries, 280 study sites. So we have a lot of data, and the aim is now to analyze disease-free survival, axial recurrence rates, life quality, comparisons of different marking techniques for the target lymph node dissection. We have a sub-study for health economics, and we hope to generate the data to make more, to give more clear information of what is the best technique. And now I promise you, and I'm very happy, I'm very thankful that we have a very strong partner in Greece who provided many data. And I was asked by Lázaro, please give us some more infos of what you know from AXSANA so far. And I'm very happy to give you not results, but I will show you some data, and you helped us to provide this data, what cohort we could define. And you will see that we will be able really to make very good analysis. So what is the statistical analysis? What are the endpoints? What we calculated? The hypothesis is that central lymph node biopsy or target axial is not inferior to axial lymph node dissection. And in order to prove this as non-inferiority, we need 1,500 patients per arm. So this shows that all available studies yet cannot provide adequate evidence that we can leave for axial lymph node dissection. So 1,500 per arm. This is the recruitment curve, which is quite impressive. We started in 2020, 3.5 years ago, and you see there's a steep recruitment. And we recruit around 100 to 150 patients per month, all node positive, all undergo neoadjuvant chemotherapy. And this is only feasible because we are a huge group and we are working together very nicely. And this is the recruitment, and you see Greece is very good. Very good is everybody who is more than 100. And so you see Greece here is on the, I think, 6th place. But what is important, you only have, where is, here. So from 6 sites. If you see Poland, 11 sites, 160. Portugal, 11 sites, 116. So you are doing really well with only 6 sites. You recruited 130 patients, which is really great. And all this helps, and you see what a big study this is. What is important about AXSANA? There's a very high quality assurance. 100% of data sets are monitored. And importantly to say that we are a low budget study. We don't have much money. But we work with PhD students. And we have 8 PhD students who do all the monitoring. Every data set is monitored. And only locked data sets, meaning if there's something not plausible, we write a query, we come back to you, you have to go to your chart, you have to answer the query, and then the data set is locked. Now, these are the interim, not results, but data that we have. And you can see here that we have more than 2,000 patients with target axial resection. We have around 1,800 with axial lymph node dissection. We have about 600 with central lymph node biopsy alone. So which is quite impressive. We try to increase the number from central lymph node biopsy alone, but it's mainly Italy and Turkey who perform this procedure in the setting. Now, these are the queries. And our monitoring team, they worked on 12,600 queries. So they went through every data set, and in 12,600 cases, they wrote a query saying, here, this is not plausible, please give us an answer. So this, just to show you what workload all this is for the monitoring team, but also for the sites who have to go back into their charts, look and answer the query. But only by this extensive monitoring we get the very high quality of the data that we need. Now the drop-off rate, which is important, and this is a huge registry. The drop-off rate is only 7.7%, but if we go into the detail, if you go into detail, only 1.7% are really lost of follow-up. We have 0.5% withdrawal of consent. This is not much. We have death 1.5%, and inclusion criteria not fulfilled. Okay, so this is quite a good rate, I would say, and the drop-off rate is a sign for the quality of the data. So I think the data quality is quite good. Now we had a data clearing process, and we contacted every site and asked our queries and so on, and tried to complete the data sets. And this is the situation that we currently have. CRF 1.4 means operation is completed and we have all the data from pathology, and CRF 1.5 means that not only the data from the surgery and histology are included, but also the treatment, the adjuvant treatment is also documented. And you see that we have available means that the data sets are completed, that the data sets are filled out. Complete means that the site says, okay, now I have completed my data set. Locked means that all the queries are answered. And these are completely finished documents, and the rate is 84%, which is quite high, I think, for such a prospective registry. So this I just said, this is a CRF form. Now, what are the follow-up data? So we have, for 1 year follow-up, we have 1,899 patients who should have the data, 300 missing, so the rate is 70%, which is missing, which we still hope to achieve. And there are 780 patients who have 2-year follow-up, and now we start with the 3-year follow-up. So the majority of patients have between 1 and 2 years follow-up, and we hope to present the final analysis in 25 or 26. Then hopefully the AXSANA will be finished. Now, some more information about this study. What is the maximum number of suspicious nodes that have been included? And this is important because we do not know what to do with a high tumor burden, for example. So the majority has 1 involved nodes. There are about 20% with 2 involved lymph nodes, but we have more than 20%, 22% who have 4 involved lymph nodes. And this will be a very important group because, as I said before, we do not know if we can go for less invasive surgery for patients with high tumor burden. We are very interested in this issue, and hopefully we can find solutions to this question. So the majority of the patients received either fine needle aspiration or core needle biopsy, which is important. Only 14% of the patients had a clinical assessment of the nodal state, which was allowed in the study, although we suggested to perform histologically confirmation of the positive lymph node status before chemotherapy. So the marking of the target lymph node, more than 2,000, almost 3,000 patients had a marking of the lymph node, so we have very good data to compare different marking techniques. What about the number of marked nodes? This is also a question. Should I mark 1 lymph node, 2 lymph nodes, 3 lymph nodes? The majority, 93%, had only 1 marked lymph node. And I think this is the standard for most patients who undergo target lymph node dissection. So the final classification, this is important, as the clinical node status, 67% converted from clinically node positive to clinical node negative, so 67, 68%. And this is something which is extremely important. We have, for patients who convert from node positive, who do not convert, and who are still clinically node positive after chemotherapy, most guidelines recommend full axial lymph node dissection. And what we found in the interim analysis of AXSANA was that 30% of these patients are node negative, histologically node negative. So myself, I would not go, although most guidelines recommend going straight for axial dissection for these patients, I would go for histological confirmation because we would overtreat 30% of the patients with a clinically node positive status. Here are the first recurrences. So 1.5%, which is within the expected range. Carcinoma of the contralateral breast is very rare. Chest wall recurrence is rare. And these are data for distal metastasis. So this is, everything is within the expected range. But these data are available and they are maturing. So what is the status of the secondary endpoints? What are the most important issues to analyze? What is the role of low volume metastasis? Meaning isolated tumor cells or micrometastasis in the central lymph node or the target lymph node. The question is, what is the rate of non-central lymph node involvement? So when we remove a central lymph node or the target lymph node, what is the rate of further lymph node involvement? So we do not have many data on this, and we will have this. This will be one of our most important secondary endpoints that we will analyze in the very near future. And the second one is prognosis. Is there an impact of micrometastasis or isolated tumor cells on prognosis? So this is the lymph node status, and we saw that 67% had clinically negative lymph nodes, and in the AXSANA study, 53.8% convert from node positivity to node negativity overall. So if we performed axial dissection in this group of patients, we would overtreat. If all of these patients receive full axial lymph node dissection, we would overtreat 50% of the patients, even more. This is interesting to see how many patients do we have with isolated tumor cells and micrometastasis. And this is the largest cohort that I know with prospectively collected data. So we have 65 patients here with isolated tumor cells and 28, 4.5% with micrometastasis. And currently we do not exactly know what to do with these patients, and we hope that with AXSANA we can provide data to solve this issue. This was a paper that was presented in San Antonio last year from the ICARO study that showed that for patients with isolated tumor cells that full axial dissection was not of clinical benefit. However, this study does not solve the prognostic information of isolated tumor cells that we hope to solve with AXSANA. This is the best paper available from Moore and collaborator, addressing the question, what is the non-central non-target lymph node involvement of patients with minimal invasive surgical staging? And you see that the rate of non-central lymph node involvement for isolated tumor cells was quite high, 17%, but the included number of patients was only 6. So we will have much higher patient numbers and really address this issue with higher patient numbers. So I already said important clinical issue is what happens with patients with high tumor burden, and so we have more than 1,000 patients with more than 4 involved lymph nodes, so we can hopefully give reliable informations. What about marking and localization techniques? You know, there are differing techniques to mark the target lymph nodes, visual techniques like the use of charcoal, image-guided wire localization with the use of a huge variety of clips and coils, and we have new probe-guided systems like the use of µasheet, of radar markers, and so on. So this paper, I think you all are aware of, that we published last year in Breast Cancer Research and Treatment, showing that with the use of µasheet and the performance of target X-ray resection, we have an excellent detection rate of 96%, and this is a procedure that works nicely. However, we want to compare it with other techniques, so in the next paper we will compare it with clips and with coils, and so far we have more than 420 patients with new markers, which I think is also a large number of patients where we can analyze them. So what about the life quality? We have an associated study of life quality. We can see the number of recruited patients. Here you can also see the performance of Greece, which is excellent because we see the availability, and you see we have these are the questionnaires at baseline and questionnaire 1 year follow-up, and for all these patients the orange ones is not available, this is available, so for the patients who were included, most patients provided follow-up data. So the planned analysis, and I discussed this with Michalis, so what do we want to know about life quality, because it's very important to know how does this translate into life quality, this sense and operation. So we will not only compare the procedures, central lymph node biopsy, target X-ray resection, target lymph node biopsy, and axial lymph node dissection, but also look at the relation between the number of resected nodes and morbidity. What about patients who have a positive lymph node, clinically negative but positive lymph node? We will have the Alliance trial we are all waiting of, but in the AXSANA study we also do a follow-up of patients with the clinically negative but histologically positive stages, because many of them will already undergo radiotherapy, and so we will in this cohort of patients compare radiotherapy with X-ray resection with regard to recurrences, but also with regard to life quality. So what is the status? And now I'm coming to the end and hope we will have some discussion. The first phase of AXSANA is accomplished. It was restricted to 4,500 patients. We will have a follow-up of patients up to 5 years, but we started a second phase, which is called AXSANA Plus, which is then an unrestricted registry. The first phase of AXSANA was rejected by the ethical approval, so we can recruit even more patients to have better analysis in the subgroups. And with this, I want to close. I thank you very much for your collaboration, and hopefully we can continue the collaboration. And this is something, this is a very nice example from Greece. This is how the data monitoring works, and you see these are the different CRFs. These are green, means every data are available. Here you see a locked sign, and this is a perfect recruitment example for perfect recruitment, because every data is provided, every data is monitored, and every data is perfect. So thank you very much for this perfect support.